Good afternoon and welcome to this ERCnet webinar. In fact, this webinar starts the second class of the ERCnet curriculum on rare diseases. My name is Francesco M and I will be your moderator today, and I'm speaking from my office in Rome. So, as always, before starting, I remind you that your microphones are turned off and that during and after the webinar, you can send your questions to the GoToWebinar application that appears on the screen. I will also ask your question at the end of the presentation. The webinar will last approximately 30 minutes, and we will then have 15 minutes available for questions. Our speaker today is Michael Materlik. Michael works at the Medical University of Gdańsk, and he is a pediatric nephrologist in the departments of pediatrics, nephrology, and hypertension. He obtains his PhD degree with a thesis on kidney and bladder function in children with posterior urethral valves. He is a member of the ERCnet Congenital Malformation Working Group and is also the regional representative for the Central Europe of the International Children Continence Society. The title of his lecture today is Posterior Urethral Valves. But today we are also innovating, and we are giving the word also to families and parents of our patients. And so before this talk, we would like to give the stage to Mrs. and Mr. Giorgetta, who are the parents of Andrea and have kindly accepted to give us their perspective as parents of children that have been diagnosed with posterior urethral valves. So please, Mr. and Mrs. Giorgetta.
Thank you, Doctor, and thanks everybody for having us. So we're here to tell you our story, and thanks a lot for inviting us. Our child, Andrea, is a 3-year-old boy. He was diagnosed PUV pre-birth, basically during a routine scan, week 31, where anhydramnios was found. We tried in agreement with the doctors to do an amnio infusion, bearing in mind that it was unlikely that it would reveal anything different. And in fact, in a couple of days, we were basically back to square one. And so we needed to decide what to do in order to solve the situation or to progress. And so basically the big choice was between a fetal surgery to apply a shunt and then wait until term, or to induce the birth and take him out and allow treatment. So first, this was a first quite important step. It was not an easy decision. And in the end, we opted to induce birth week 33. I think it turned out to be the right choice. He was born with a good weight and size, 2.5 kilos, so actually pretty big. We did have some complications due to premature birth that kept us busy for a couple of months in the ICU and pathology care unit in Milan, including, of course, the surgery for removing the obstruction in the valve, for cutting the valves. And so in that time, we started understanding basically what was happening, and so everything clearly was happening so fast around us, and it all happened in a matter of a few days. And so for us as non-expert, it's really complicated to get around things. And so that we have a vivid memory of some initial meetings where we kind of understand what can happen in the future, the likely need for treatment, basically monitoring all these indicators, these numbers. And so at the very beginning, so we would like really to share with you what was running through our minds and what kept us, up at night in a sense. So at the beginning, obviously, really happening everything in a matter of a few days. Will the baby leave? Even maybe sometimes sort of stupid questions, but you're feeling a little lost at the beginning, and so immediately you start thinking about what type of childhood will the baby have, will he need dialysis and a transplant, and if so, by when? And then the first things we were a bit finding it difficult to understand was why don't we basically make something, So from our perspective, it was difficult to understand that we just couldn't, intervene. We couldn't fix it, and so it was difficult at the beginning to keep calm and wait and see how things evolve. No? So that was the first big difficulty we found. Then where we are today is again, Andrea is 3 years old. Obviously, we are monitored every approximately 6 months with tests for both the nephrologic and the urologic part, with some ups and downs, but I would say he's fairly stable at 0.7 of creatinine. We haven't seen any urinary tract infections, but to be fair, we haven't toilet trained him yet. We've just waited a little longer to make sure he's bigger, let's say, to understand what to do or understand better what to do. And I would say he's growing well. He's 95 centimeters, almost 15 kilos. And so for us, not knowing, or anybody not knowing, actually, when you see him, he's just a normal guy, so normal child. But we do remain conscious that it's likely a matter of time before there could be the need for a real treatment. And so clearly our doubts and questions have evolved over time. So we did understand what that we need to be patient, and we need to. It was extremely important to have a diagnosed PUV early on, so even before he was born, and so we could immediately take action. And so now our main questions are around the future and what can we do in order to, if of course not improve, but at least manage the situation. And so we are spending a lot of effort in making sure that the diet is as good as it could be, or we continue to think about what can be the childhood, and even going forward, in terms of, can it be normal doing sports, going to school and so on. And of course the future is in our minds of what we can expect when, how sudden can any changes be, and how do we see it, so those clearly we have normally 6 months of normal life, let's say, and then when we are closer to the checks, it's a bit more hectic for us in our mind, and everything is always around what we can do, even to the point of thinking, I don't know if it is rational or not, but thinking even, should we do something to get ready mentally or physically as potential future donors. In the end, we're just parents with no medical experience at all, and then of course thinking about the specific moment that we're living nowadays. We try to be super cautious about COVID, really extra cautious, and I don't know if this is actually of any difference for a normal child or not, but we try to do it. And then of course a bit longer term, we wonder, what can medicine, what can you actually can you do in your studies, in your research in the future, either for Andrea or for other children in the same condition. So that is of course in our mind. And so very quickly, this is a little bit our story, and we try to list a few thoughts that we had in our mind in this journey that really maybe we would need an hour, not 5 minutes to tell you about. But so maybe one very important point for us was that with no medical experience or knowledge, this was very difficult for us at the beginning to accept or to understand, because everything happened in a few days. It was very difficult to really comprehend what was going on and take the right choices. So clarity of communication for us was very important. Even if you tell us things twice, 3 times, probably we need to listen many times to really understand something. Because every word we hear, probably we build on it in a way. And then your support in taking choices, like the ones we've taken already with the birth, or the ones that we may need to take in the future, your support is extremely important, because really we have no real knowledge. And so help would be absolutely critical. And then in our experience, at the beginning was difficult, the wait and see period, as I was mentioning, and that's something that we got help from you. And last, maybe is in today's world, of course, every patient or parent maybe have different needs, and so even your support is much appreciated holistically. Let's say, if we need information or we need support, that's really important for us. So thanks a lot. I tried to be very quick, and I'm happy to take any questions at the end of the presentation. Back to you.
Oh, well, really, I personally would like to thank you so much, Mrs. and Mr. Giorgetta, for this very enlightening presentation and testimony. I think that those of us who are old enough have heard your stories, similar stories several times, but I think it's always very useful to listen to them again, and in such explicit and clear way. I think this brings a very concrete light to the presentation of Dr. Maternik, to which I will give the stage at this stage. Please, Michael.
Thank you for a kind invitation to the organizer for this, to give this presentation about the cerebral valves.
Apologies if I interrupt you. We don't see your slides.
But I cannot do. Stephanie was
to share your screen. I think that in the switch between Mr. and Mrs. Giorgetta and you, I think we're okay. Now we see them. You can go full screen, and the stage is yours.
Okay. Thank you. Okay, it's working.
Yes.
So once again, I would like to thank the organizer for this kind invitation, for this webinar, for presentation for this webinar. I don't know if for all questions, but some of them asked by Mr. and Mrs. Giorgetta, I will try to answer during my talk. During the next 30 minutes, I will briefly take you through the following topics, like the incidence, pathophysiology, antenatal and postnatal diagnosis and management, late presentation on PUV, and the kidney and bladder consequences of this congenital malformation, including transplantation problems. When we look to the data for prenatally detected lower urinary tract obstruction, a total prevalence is 3.3 per 10,000 births. If you look for live births, prevalence is decreased to 2.2 per 10,000 births. The most common type of lower urinary tract obstruction is posterior urethral valve. But important to notice is fact that 22% were complex cases with other malformations and chromosomopathies. Data presented by the British Association of Pediatric Surgery, including all patients referred to participating pediatric surgical units in the UK, with confirmed posterior urethral valves during 1 year, reveal an incidence of PUV of 1 over 3,800 male births per year. Comparing distribution of cases according to time of recognition now and 3 decades ago, we can observe tendency to aerial diagnosis due to development of the prenatal ultrasound. Typically, posterior tall falls arise from veromontum and fuse anteriorly, causing the obstruction. In a minority of cases, PUV is recognized as a round membrane with a hole in the middle. As the cloaca is dividing, the orifice of Wolffian ducts migrates from anterolateral position in the cloaca to Miller trabeculae on posterior wall of urogenital sinus. Migration path is normally lateral and posterior, remaining inferior ureteral crest and plica colliculi. When insertion of Wolffian duct into cloaca is abnormal, more anterior, migration results in formation of abnormal ridges, the posterior urethral valves. PUV is a malformation with different grades of severity, from very severe forms causing almost total obstruction to the milder forms, explaining the wide spectrum of clinical consequences, from death due to the pulmonary hypoplasia just after birth, end-stage renal disease from birth, to slight bladder dysfunction with normal upper urinary tract appearance and function. When we're talking about the prenatal diagnosis, counseling and intervention, which takes place around 20 weeks of gestation, we need to remember the timeline of organogenesis of the kidney, lungs, and urethra. Organogenesis of the kidney is completed between 12 and 14 weeks of gestation. The development of the urethral valves, so the caudal migration of the Wolffian and Müllerian ducts, occurs even earlier, during 6 to 8 weeks of gestation. The definitive formation of urethra is completed by the 12th week of gestation. Normal amniotic fluid volume, which is essential for bronchial branching during the critical canicular phase of lung formation, occurs between 16 and 18 weeks of gestation. Fetal urine is the major component of the fetal waters needed for the proper development of the lungs. If we look for the pathophysiology of the malformation and its influence on the bladder, the high pressure during the storage and voiding phase caused by PUV increase the stretch and bladder wall hypoxia. It leads to the trousseau hypertrophy and ingrowth of collagen and extracellular matrix. As a result of obstruction, the bladder generates higher pressure, which lead to development of hydroureteral nephrosis, vesico-ureteral reflux, and renal dysplasia, but also to the glomerular and tubular dysfunction of the existing nephrons. Obstructive consequences of the bladder are multimodal. Hypertrophy of the smooth muscles and increasing deposition of extracellular matrix, which has influence on the passive and active properties of the bladder wall, reduction in contractile capacity of the smooth muscles, and need for generation of higher pressure to pass urine. There are some recognized protective mechanisms which may be present in patients with PUV. Unilateral reflux or urinary extravasation or patent urachus or large bladder diverticulum lead to the compensation of high pressure and can prevent some of kidney damage. Primary renal dysplasia is not the only finding in PUV kidneys. In kidneys removed postnatally due to the lack of function, secondary changes and interstitial fibrosis or interstitial nephritis were present in almost all cases, showing that obstruction has also devastating influence on developed kidney structures. So we reach for the first pool questions, just to recognize the audience. So the question is, are you involved in prenatal counseling of patients with lower urinary tract obstruction in your center?
So, Mikol, you have about 40%, 41% say yes, and 59% say no.
Okay, so almost half and half. So this part, which is coming, will be just some remind for this half who doing co-swelling, and maybe something new for these people who are not. So during a previous ARCnet lectures, we had the great opportunity to listen an excellent webinar on prenatal management of luto presented by Professor Nicola Persico from Fetal Medicine in Milano. So therefore, I will make just some brief remarks on this topic. For antenatal diagnosis of lower urinary tract obstruction, several indicators have been proposed, and the clinical score presented by Fontanella seems to be useful, non-invasive and sensitive. It is composed of 5 indicators. 3 of them are ultrasound finding, like megacystis, urethral dilatation, and oligohydroamnions, and the remaining 2 are clinical information on the sex of the fetus and time of referral. According to this scoring system, it's possible to evaluate the risk of lower urinary tract obstruction with quite good sensitivity. A novel tool for the better imaging of the lower urinary tract obstruction, both kidney and bladder, is MRI and its 3-dimensional reconstruction. This may provide additional information on the anatomy of the obstruction and may be helpful in decision-making and performing fetal cystoscopy. The existing prenatal predictors of end-stage renal disease performed on the basis of single anatomical lesions listed on the slide have low sensitivity and specificity. In a retrospective review of North American Fetal Therapy Network, 1/3 of children diagnosed with lower urinary tract obstruction, but with normal amniotic fluid volume mid-gestation, required renal replacement therapy. So it was proposed the combination of several anatomical predictors, including oligohydroamnions, increased parenchymal echogenicity, and cystic changes of the kidney parenchyma, may give better prediction of renal function after birth. Recently, a single non-invasive predictor of postnatal kidney function as renal parenchyma area has been proposed as a prognostic marker of early renal function and perinatal mortality. This novel marker is based on ultrasound assessment, so it's widely available. But also we have biochemical predictors of end-stage renal disease, which may be measured in the fetal urine and serum. So fetal urine and serum analysis for electrolytes and for beta-2 microglobulin are suggested to provide additional prognostic information regarding renal function in childhood. However, these are invasive methods which require high specialist care centers and to be performed and require further validation. A promising tool in prediction of postnatal renal function is the 12-peptidide signature from fetal urine. In a preliminary study from France, it shows very good sensitivity and excellent specificity in predicting early end-stage renal disease. Better the standard fetal kidney characteristic like oligohydroamnions or amniotic fluid volume or fetal urine biochemistry. Right now, there is ongoing multi-center antenatal trial for validation of this method, and we are expecting results in the next 2 years. In spite of 30-year history of prenatal intervention in lower urinary tract obstruction, the main question remains on selection of patients who will benefit from the procedure in short and long term. 2 staging systems have been proposed to grade the severity of prenatal lower urinary tract obstruction in relation to postnatal survival and residual kidney function. One proposed by Fontanella is simple based on bladder volume and gestational age at first presentation of oligohydroamnions. A second classification proposed by Ruano divides the disease into 3 grades of severity using a combination of ultrasound and fetal urine characteristic, with the middle group recommended for fetal intervention. This classification was discussed by a panel of experts from Society of Fetal Urology. They agreed that Group 1, there is no need for the intervention, and in Group 3, intervention may prevent pulmonary hypoplasia, but not postnatal renal impairment. Recently, there are 2 modes of antenatal intervention: vesicoamniotic shunting and fetal cystoscopy. Both are not free of complication, of course, with preterm delivery reaching 20% and urological complications described. These procedures are limited to very highly specialized theater center with access to neonatal intensive care unit, pediatric nephrology, and pediatric urology. So we reached the next poll question. So I would like, because we finished this part about the prenatal diagnosing management, so I would like to know how many new patients with PUV did you see in the last year?
So, Mikhail, 13% have seen more than 5, 13% have seen 4 to 5, 29% have seen 2 to 3, and then 45%, so nearly half of the audience, have seen between 0 and 1 patient.
Okay, so we've got more or less experienced audience. So we are going to the postnatal presentation. The majority, or at least half of patients, are still diagnosed postnatally in different periods of life. Both the urological and non-urological manifestation presentation will depend on the age at diagnosis. During the neonatal period, non-urological symptoms may be related to pulmonary hypoplasia or oligohydroamnions, and urological symptoms like poor stream or palpable bladder may be seen. In later infancy, no specific symptom like failure to thrive, dehydration may be present. Among urological symptoms, UTI and urosepsis together with weak stream may be observed. In cases recognized in the late childhood, symptoms may be related to the kidney insufficiency, like hypertension or poor growth, or late symptoms may be related to the abnormal bladder function, like daytime or nighttime incontinence, urgency, small bladder, etc. In retrospective analysis of indication for VCUG in patients who are diagnosed with PUV postnatally, 2 distinct groups can be observed. In children below age of 1, the main indication was antenatal hydronephrosis and UTI. And in old age, lower urinary tract symptoms and UTIs were the main indicators. Postnatal management of newborn suspected of PUV requires immediate urinary catheterization. Once drainage is established, the patient may have large urinary water and solute losses due to tubular dysfunction. This tubular dysfunction resulting in inability to concentrate urine or normally absorb solutes, mainly sodium and potassium. To evaluate kidney function, creatinine level need to be measured at least 48 hours after birth. Otherwise, it reflects rather mother kidney function than neonate. Some patients with PUV due to the tubular dysfunction may have renal tubular acidosis. So careful monitoring of serum electrolytes, include serum bicarbonate and fluid status, is really required, and replacement of the fluid electrolytes should be done according to these measurements. In the male neonate with high suspicion of bladder outlet obstruction caused by PUV, insertion of 6 French feeding tube rather than Foley catheter is indicated. We try to avoid the Foley catheter due to the risk of the obstructing the urethral orifice by inflated balloon in small PUV bladders and the risk of causing bladder spasm. Then VCUG is supposed to be performed. If transurethral catheter is used, 6 French catheter may be replaced for larger one to prepare for cystoscopy. In postnatal ultrasound examination, signs of renal dysplasia and obstructive uropathy may be seen. The renal dysplasia signs are hyperechogenic cortex, absence of the corticomedullary differentiation, and thinner cortex with that cyst, which is seen. Also, we can observe dilatation of urinary tract. It means hydronephrosis and urethral dilatation. And in some cases, we can observe perirenal urinoma. When we evaluating the bladder finding in ultrasound, suggestive for bladder outlet obstruction are thickening of the bladder wall or bladder wall trabeculation as it present on the slide. But the vesicular retrography is still the gold standard imaging modality for diagnosis of posterior urethral valve. The patient is catheterized and contrast agents injected into the bladder. Fluoroscopy is then used to observe voiding and to identify the reflux. It's necessary to perform oblique view for better visualization of urethra. We can see the features suggestive of posterior urethral valve, which include elongated and dilated posterior urethra and prominent bladder neck. Also, the vesicular reflex may be present in up to 50% of cases. Most infants with confirmed PUV undergo transurethral valve incision as a primary procedure. Indications for the choice of other modalities are or unstable preterm infant, or severe deterioration of kidney function, or increasing hydroureteral nephrosis without improvement after catheterization. As it was shown in a recent British study, the vast majority of patients independently when obstruction was diagnosed, if it was prenatally, postnatally during the first year of life or later, have done transurethral incision as an only procedure. Different pictures of PUV may be seen during the cystoscopy due to the fact that the whole spectrum of severity of obstruction is in this group of patients. From very severe forms on the slide left up, leaving just a small non-obstructed part of the urethra, to the very mild cases resultant in just bladder dysfunction without changes in upper urinary tract. Cystoscopic valve ablation, as I told, remains the treatment of choice in managing the patient with PUV. But the data on influence of other initial urological treatment is rather conflicting, and it's not clear if temporary vesicostomy or ureterostomy have an impact on later kidney function or not. But incision of the valve, of course, is not the end of the story. Following valve ablation, it's necessary to reevaluate the upper urinary tract and the effect of urethral incision. It may be done with renal ultrasound, VCUG, and MAC3 diuretic renography within 2 to 3 months after initial procedure. In the case of hydroureteral nephrosis, progression or urethral obstruction, the control cystoscopy is indicated. In some cases, upper urinary tract dilatation may persist in spite of valve ablation. There are several possible causes, like residual valve or iatrogenic stricture of the urethra, vesicoureteral junction obstruction due to the bladder wall hypertrophy, or polyuria due to the poor concentrating ability, or CKD, or both, Also, it can be seen bladder neck hypertrophy and hypoosmotic residual. Another issue in children after valve ablation is urinary tract infections. The most common complication within the first year of life in children with PUV due to the high incidence of VUR and high incidence of bladder dysfunction with possible post-void residual. They, of course, may lead to the further kidney damage and scar formation, but recently published randomized trial value of circumcision in this group of patients suggests an essential reduction in the incidence of febrile UTI following this procedure. So the authors conclude that valve ablation should be performed always together with circumcision in PUV boys. So now we reach the third question, which is which timing of PUV diagnosis is associated with the best prognosis from normal kidney function?
Okay, Mikhail, that was a tricky question. So
Yes.
you have 59% saying antenatally diagnosed. I honestly don't know the answer to this. Diagnosed during the first year of life, 9%. Diagnosed after the first year of life, 20%, 21%. And they have equal prognosis for kidney function, 11%. I would personally assume that antenatally they are also more severe, but I'm curious to know the answer.
Okay, so the answer is not easy, because if we look at the short-term recent British data of kidney function and appearance 1 month post-valve removal, they found that if patient is detected prenatally, they've got the higher plasma creatinine, greater hydronephrosis, and greater ureteric dilatation, and renal dysplasia features are more likely in these subjects antenatally detected. But if we look for different data showing presented by the Brazilian group, in the longer term, they show no difference in kidney function between the prenatal and postnatal diagnosed patients. We can speculate that this difference may also due to the different prenatal diagnosis policies or longer time of observation, but it's still, there are different data. But also, we've got other consequences of the posterior ureteral valve, like tubular dysfunction. And we can expect short and long-term consequences like significant post-obstructive diuresis or transient hyponatremia or tubular acidosis and decreased kidney concentration capacity, even in patients with still normal GFR. Interestingly, polyuria is present in half of children diagnosed prenatally and in quarter diagnosed early postnatally. It's maybe a further indicator of kidney parenchyma damage and disease severity. Another complication is hypertension. Incidence of hypertension in patient PUV varies among studies, but definitely it's higher than in general population. According to the recent HICALI study, they show it's related to the increased plasma renin activity, and they try to explain that by a tubular glomerular theory, where glomeruli without tubular pulp producing more renin, which is leading to hypertension. When we're talking about the long-term consequences of posterior valve, need to be underlined that this group of patients constitute up to 11% of all pediatric end-stage renal disease, according to the North American Pediatric Registry. So probably we reach the last full question. I'm curious, what is the cumulative risk of end-stage renal disease in patients with PUV when they reach adulthood? How I would like to ask the audience.
Right, Mika, you have 14%, say about 10%. The majority, 44%, say 25%. And then you have 29% that says about 50%, and 13%, 75%. So I would say that 75% of responders says that it's between 25 and 50%.
Okay, for this question, it's easy answer according to the data, because we've got quite a big data in two retrospective American PUV cohorts, one including 250 children and another including 700 children diagnosed in their first month of life who underwent endoscopic valve ablation or urinary drainage intervention. The cumulative risk of development of end-stage renal disease was quite equal and was around 25% at the age of 20. But also we are looking for other prognostic marker of CKD and end-stage renal disease and the early stages. So the role of nadir serum creatinine as a prognostic marker has been acknowledged for over 2 decades, despite different reported threshold between 0.8 to 1 milligram per deciliter. A higher risk of long-term renal morbidity has been consistently linked to the nadir serum creatinine values above this threshold within the first year of life. Recent work appears to stratify the risk of CKD in 3 groups: low risk below 0.4 milligram per deciliter, high risk above 0.85 milligram per deciliter, and intermediate risk group in between. There are further postnatal prognostic markers of future chronic kidney disease or end-stage renal disease in boys with PUV, and among them renal dysplasia features like decreased corticomedullary differentiation and quite novel one like decreased renal parenchyma area calculated by dedicated software. All of them can somehow predict the risk of development of end-stage renal disease, but also persistent lower urinary tract dysfunction increase fourfold the risk of developing CKD. Next issue, or what I would like to focus, is the bladder function in children with PUV, which evolved from a small spastic poorly compliant bladder just after release to the obstruction through the bladder of activity, causing daytime and nighttime incontinence, to the large bladder caused by myogenic failure related to the overflow incontinence, significant post-void residual, and further risk of upper urinary tract deterioration. In fact, evaluation of the bladder function in children with PUV do not differ from evaluation from other bladder body dysfunction. This is summarized in paper of International Tube Incontinence Society. There are several tools to evaluate the bladder function. First one is the 4-hour bladder observation. With this tool, we can evaluate bladder function with ultrasound measurement of post-void residual, and this tool can be used even in infants who do not control the bladder. During this non-invasive test, we can evaluate number of voids, voided volume, and post-void residual. In older children, 48-hour frequency volume chart may be used to evaluate maximum voiding volume, voiding frequency, and total urine volume. Additionally, we perform 14 days bladder diary to evaluate frequency of incontinence episode during the day, during the night, urgency symptoms, and resist episode. We can also evaluate nighttime urine production, wetting the diapers after wet night, and adding the first voiding volume in the morning. Another non-invasive tool for bladder function evaluation is uroflowmetry. Would let us to evaluate the voiding phase with the voiding curve shape, Qmax, post-void residual. But the most comprehensive evaluation can be performed by an urodynamics or video urodynamic test, during which both filling and voiding phase are evaluated, and type of bladder dysfunction may be characterized. If we characterize the bladder dysfunction, we can go to the treatment, and this treatment is both pharmacological and non-pharmacological. If we're talking about the pharmacological treatment, decreased bladder compliance and bladder activity are clear indication for anticholinergic use. But it's necessary to monitor side effects, which are quite common, and post-void residual with repeated uroflow or ultrasound. When we deal with persistent bladder neck hypertrophy and high post-void residual, alpha blocker like terazosin, doxazosin, or tamsulosin may be used, although this is the off-label indication. In some cases of persistent polyuria, supranormal doses of desmopressin may be useful. But also we've got the non-pharmacological mode of treatment, which varies from non-invasive urotherapy consisting of proper fluid intake, time voiding or double voiding to prevent post-void residual, to the more invasive options as nocturnal bladder drainage to prevent overdistension of the bladder and overdistension of upper urinary tract. Another option is clean intermittent catheterization, which is introduced in ineffective emptying bladder and in recurrent UTI. It's important to note that transurethral catheterization in children has low adherence due to the urethral pain and Mitrofanov procedure, which means creation of the stoma for catheterization is often necessary. Bladder augmentation is usually the last option when other treatment phase or the patient is prepared to the transplantation and his native bladder is not properly compliant. But after augmentation, we can expect some complication like increased rate of urinary tract infection, metabolic changes, kidney and bladder stone, and some others. When we look for the catheterization rate in patient PUV, it increases over time and may be needed up to 50% of cases by the age of 20. So finally, there is a group of patients who got delayed presentation on PUV. It need to be suspected in boys with obstructive pattern in uroflow or in overactive bladder, refractory to cholinolytics and other treatment modalities. This late presented PUV may be difficult to diagnose with VCUG, and rather cystoretroscopy may be necessary to make the diagnosis because late presentation can reflect the milder form of this congenital malformation. But when we're dealing with a boy with posterior to valve awaiting renal transplantation, the pediatric nephrological team faced two major questions. Does the bladder store urine safely at a low pressure? If not, augmentation cystoplasty is needed before transplantation. to minimize wall complications of suppressive therapy. And the second question is, does the bladder empty safely and completely at a low pressure? If not, CIC through the urethra or Mitrofanov to native bladder should be introduced. To support this regimen, there are recent data from Spain about graft survival comparing patients after transplantation who are on CIC against patients without CIC. And we can see on the upper graph there is a better graft survival among patients on CIC. The same was with patients who have performed Mitrofanov procedure against this one who do not have this catheterization stomach performed. But in general, when we look for the results of the transplantation patient with PUV compared to other forms of urinary tract malformation leading to end-stage renal disease, it shows that up to 10 years after transplantation, graft survival was similar. Later on, there was an increase for graft failure in PUV recipients, probably due to the higher rates of UTI and bladder dysfunction. So, fortunately, we reach summary, and I would like to conclude my presentation that antenatal diagnosis and treatment of PUV is possible, but recent data failed to show long-term benefit for future renal function so far. PUV diagnosis carries like 50% risk of long-term risk for CKD and 50 to 30% of end-stage renal disease by the age of 18 years. We also need to mention that the bladder dysfunction are common in patient PUV, and in most cases evolve with time from small, low compliant bladder to the large distended bladder, which is unable to empty. And the last, the careful bladder evaluation before kidney transplantation and introduction of CIC or augmentation cystoplasty may improve graft survival. Thank you for your attendance. I'm of course looking forward for the questions, but before that, I would like to invite all of you for the next ARCnet webinars. Thank you for your attention.
Thank you, Michał. It's hard to be more complete than what you did. I think we learned a lot, and I think we have, let's say, 10 more minutes for questions. And so please send in your questions and I will ask them. So let me open my screen now so that I can see them. Okay, so the first thing, the first message is actually for Mr. Sis and Mr. Giorgetta, and I read to you here a message. Thank you so much for sharing your story. This is of incredible value for us. All the best for you and for little Andrea. So it's a very good way of beginning this. Thank you. And I think we all join Dr. Van Massenhoven. Apologize, Jill, if I don't pronounce your name well, in this message. So, Dr. Renkema, as a researcher, I'm very thankful for the presentation by the parents. I hardly met parents and patients, and this is very valuable to listen. So again, a message for the parents. So now it's for you, Michał. So Dr. Moore is asking you, when do you use oxybutynin in infants with PUV?
As I said, in low compliant bladder or in bladder with overactivity, we use cholineolytics or oxybutynin or solifenacin, which is other cholineolytics to try to distend the bladder.
All right. So Dr. Jungans is asking you if you could comment on laser incision or cold incision and the long-term outcome of the two methodologies.
Once again, the cold incision and
the laser incision.
I'm pediatric nephrologist at first, so I'm not performing these procedures, but at least in the literature, there's the cold knife is preferred due to the smaller number of complications like secondary strictures comparing to the laser. But these complications are not very often. But in our pediatric urology unit, the cold knife is used since many years.
So now Dr. Altahiri is asking you a question. I'm not sure I understand it completely, so I'm just going to read the question as it's written. Do you support the antenatal intervention if the renal outcome is not significant? So I suspect if there is not a big kidney damage, I don't know. And Dr. Altahiri, if you want to send in a new message to precise your question, feel free to do so, please.
It's rather kind of ethical question and question which need to be discussed with the parents, because as we heard in story of the parents, we need to in my opinion, we need to show them whole picture. So what do we expect later on? What the risk of chronic kidney disease, end-stage renal disease, if there is a risk of early start of renal replacement therapy, all this picture should be given to the parents, and decision should be like consulting with them. Otherwise, we cannot decide beside opinion of the parents.
Dr. Kaptwe Motwe, I hope I pronounced well the name, is asking you what is best, dilatation of the urethra or surgical resection?
Oh, definitely the intersection of the valve is the treatment of choice, not dilatation per se, because it's not removing the valves.
Okay. So Dr. Said Conti is asking you, how will advocating early delivery helps in improving lung and kidney outcome?
In fact, it's a tricky question, because we need to put on the weight two things. If prolonged pregnancy leads to further devastation of the kidney, or on the other weights is preterm birth also leads to the same consequences. So it's not the easy question for that to perform preterm delivery to prevent kidney function. It always depends on how the kidney looks like, how the bladder looks like, what we can say about the development of the child, on which stage of development of gestation is the child. So many factors are influencing on that.
Would you like to make a comment on steroid pretreatment before delivery? Would you like to make a comment on steroid pretreatment before delivery for lung maturation?
Steroid treatment, as far as I know, is mainly introduced to faster development of the lungs in the preterm babies. So yes, if this decision is to make preterm delivery, it's worth it to give steroids before this delivery.
Okay, we have 6 more questions, and I will stop the question. So if you want, you can email Dr. Maternik also, but so don't send in more questions. So we have 6 more questions for you. So so Dr. Komak is asking you, at what age do you start using solifenacin?
In fact, and I need to admit that it's off-label use because it's on label is for neurogenic bladder, for neurogenic overactivity, but we start to use it in very early stage in the first or second month of life if there is a thicker bladder wall and we expect the low compliant bladder. But it's my personal experience and it's nothing which is, you know, on label.
So Dr. Abazi liked very much your lecture and asking you if urodynamic studies should be done after kidney transplantation and bladder augmentation, and if yes, how frequently?
No, I'm not seeing a great value of urodynamics after bladder augmentation because we expect there is a high volume, low pressure bag which collected the urine. We perform sometimes urodynamics in augmented bladder if we can see deterioration of the kidney function, or we can see the leakage in the stomach, for example, to see the pressure, how it works. But usually we do not perform very often and routinely urodynamics in patient after augmentation.
Dr. Moore is asking you, how long do you use oxybutynin and when do you reassess?
We try to assess after 2 to 3 months, and again, the assessment is pretty tricky. Think if the patient has a reflux, because doing the urodynamics when the patient is the reflux, not really answering us what is the bladder capacity and behavior, but the whole system is also involved with the ureters and pelvis of the kidney. So, but we try to reassess, and I find it very useful, this 4-hour bladder observation in the young children to evaluate the bladder capacity, how often they urinate during this 4-hour period. So not only urodynamics, but also this 4-hour observation may be useful in treatment with cholinelytics.
Dr. Knops is asking you how sensitive is the VCOG for diagnosis valve, and should a cystoscopy be performed in all children with a high clinical suspicion of valves and or children who are admitted for an anti-reflux operation?
Okay, so there's some of I'm in favor of this if we've got this high suspicion of the valve, so thickening bladder, bilateral reflux, and so on. Even if it's not visible in VCOG, cystoscopy should be performed. The second one, however, right now, recently in Europe, at least in the United States, most of the anti-reflux therapies is through the urethra cystoscopy, anti-reflux injection. So during the same procedure, you can evaluate the urethra and see if there are valves or not.
Dr. Mikalev is asking you, in which circumstances a Mitrofanov procedure should be performed?
If we've got the myogenic failure and huge bladder, which leads to deterioration of upper urinary tract, and patient refuse catheterization to urethra, you can discuss with him the Mitrofanov, which makes easier to catheterize couple times a day, especially that this myogenic failure usually touch the teenagers, so they are not very cooperative. So we need to find the solution that try to start to CIC, and this Mitrofanov is one of the solutions.
And maybe I will ask, can you maybe for the audience, could you also comment on the fact that some of these patients, especially if you need to perform a Mitrofanov, these are patients with severe disease, so they may need dialysis. Would you comment on the fact that putting a Mitrofanov on a child that may potentially need peritoneal dialysis, would you like to comment on this?
Yes, sometimes it's difficult decisions, but also you can perform this this procedure, and but keeping in mind, because usually the stomia position is in the umbilicus, so peritoneal dialysis is still possible if the optimal distancing between these two stomias are available. But I think the Mitrofanov usually is done earlier than we put patient on dialysis.
Yeah. So 2 more questions to go, Mikan. Dr. Ezezobor is asking you, how do you keep the feeding tube from falling off when used continuously to decompress the bladder?
So basically, we use the plaster and quite to stick the feeding tube, because we believe if there is a small bladder after the PUV, the Foley catheter with the balloon make more harm than good. So if they fall, we try to put another one, but definitely we try to use the feeding tubes instead of Foley catheters. Okay,
and the last question is again from Dr. Al-Daheri, and what I believe it's a she. She's asking, if bilateral high-grade reflux is diagnosed in association with PUV, how do you deal with the reflux after you relieve the obstruction?
Usually, and there is quite a lot of data, the degree of reflux after relief of obstruction decreases. So the wait and see attitude and put the patient on the antibiotic prophylaxis, it's the best option, because doing surgeries or anti-reflux surgery in very early stage, in my opinion, it's too early. Rather, we need to wait and see, and usually the grade of the reflux decreases.
And then I have one last question for you, just a quick answer. If you have a very severe disease, do you prefer a decompensated large refluxing bladder, or do you prefer a small hypertrophic bladder without reflux?
Definitely large. I prefer large bladder instead of, because then I've got the reservoir for the urine with the low pressure, and it can be emptied and preserve kidney function, definitely.
Completely agree with you. So again, Mikal, that was a very, very enlightening talk. I think, again, thank you so much for the family, Georgetta, for sharing their experience with us. I think it's a very nice initiative, one that we will certainly repeat again in future webinars. And I thank you all for your attention. Thank you very much.
Thank you very much. Bye.
Thank you. Bye.